registered nurse, and this is Nursing Analysis. Today, we will continue our pharmacology for the cardiac system, and in this video, we will focus on angiotensin receptor blockers, commonly referred to as ARBs. Most of these medications will end with the word part, sartan. Our body has a system known as the RAS, or Reninangiotensinaldosterone system. This system is utilized when the blood pressure becomes too low. Renin is produced in the kidneys, so when the kidneys detect low blood pressure or low sodium levels, renin is released. This release of renin stimulates the liver to release a protein called angiotensinogen. The combination of renin and angiotensinogen formulates angiotensin 1. Angiotensin 1 travels to the lungs, where it is transformed by an enzyme in the lungs known as ACE, or angiotensin converting enzyme. This enzyme converts angiotensin 1 into angiotensin 2. Angiotensin 2 then travels to type 1 receptors that are found in the vessels of smooth muscles and in the adrenal glands, which causes vasoconstriction. This will increase systemic vascular resistance, which will increase the blood pressure. Angiotensin 2 also stimulates the release of aldosterone from the adrenal cortex, which causes sodium and water retention and potassium secretion. We will increase the blood volume and further enhance the increase of the blood pressure. So, I bet you're wondering, how do we stop the RAS system? More specifically, how do we stop the RAS system using angiotensin receptor blockers? Well, first, ARBs block angiotensin 2 from attaching to the receptors in the vessels of the smooth muscles, which will prevent them from constricting. Instead, they will dilate, which will decrease systemic vascular resistance and decrease the blood pressure. Secondly, by blocking this attachment, aldosterone will not be released by the adrenal cortex, so sodium will not be conserved. Instead, potassium may begin to accumulate. We will discuss this concern later. For now, we will continue the discussion of sodium. Now that it is not being retained, there will also be no additional water retention, and the blood volume does not increase, which means the blood pressure will not increase. So our therapeutic effect is decreased systemic vascular resistance, which decreases blood pressure. So what does this mean for the heart? Well, in the heart, this means that we will be decreasing the preload, which, remember, is the amount of filling in the left ventricle during diastole, and will also decrease afterload, which you can remember is the amount of pressure the heart overcomes to contract. All these actions will also decrease the body's oxygen demand. Now, if you watched my video on ACE inhibitors, you will remember that ACE inhibitors stop the RAS system by blocking the enzyme ACE in the lungs. Remember, ACE is responsible for the breakdown of bradykinin, which is an inflammatory substance in the lungs. So, when we block ACE, we block that breakdown, which produces that dry, nagging, hacking cough. Well, when taking ARBs, on the other hand, we do not block ACE, and we leave it available to continue the breakdown of bradykinin, so we do not get that dry, nagging, hacking cough when taking ARBs. Also, the potassium retention with ARBs is not as severe as with ACE inhibitors, although we still need to monitor the potassium levels. Now, let's talk about the therapeutic uses for ARBs. ARBs can be used to treat hypertension, heart failure, and they can also be used for stroke prevention. They also can be given to delay the progression of diabetic neuropathy. Here is a list of some of the most common ARBs. So, let's discuss some nursing interventions and considerations concerning angiotensin receptor blockers. Adverse effects can include angioedema, so we must advise the patient to monitor for skin wheals, swelling around the eyes, lips, tongue, and the need to notify the MD if any of these reactions occur, so the medication can be discontinued. Severe effects of angioedema are usually treated with epinephrine. We also must remember that ARBs are a Category D medication. This means it can cause fetal injury during the second and third trimesters of pregnancy. So we must advise the patient to notify their provider if they suspect they are or are planning to become pregnant, so an alternative medication can be prescribed. These medications are contraindicated in patients who have renal stenosis when present bilaterally or when it's present in the patient with a single remaining kidney. Use cautiously in clients who experienced angioedema while taking an ACE inhibitor. Other antihypertensive medications may have an additive effect when used with ARBs. We must educate the patient on the importance of healthy lifestyle choices, which include regular exercise, weight loss, smoking cessation, and low sodium diet to maximize the effects of antihypertensive therapy. These medications are taken by mouth and are available in a single formulation or in combination with hydrochlorothiazide. These medications can be taken without food, but can be given with food if GI symptoms occur. Monitor renal and hepatic functions to alert the doctor for possible development of renal and/or hepatic failure, as well as to signal the need for a reduction in the dose. Provide comfort measures such as a quiet environment and relaxation techniques to help patients tolerate drug effects. And now for our favorite part of the video. It's our rhyme time review. With no time to rehearse, I am Ronnie Decker, registered nurse. I guess it could be worse. So let's begin with the first of the following verse. The blood pressure is low, and the body will know. To the kidneys a signal will go. I bet you are now grinning. You remember its ending and what is involved with what the kidneys are sending. We see the picture in this scripture. It makes us quiver. Angiotensin and renin meeting in the liver. Yes, we are not done. It's just begun. Introducing angiotensin 1. On to another place, the respiratory space, as we save face and engage with ACE. You need no clue. You know what to do. Everyone repeats angiotensin 2. We aim to block it, or there will be no pharmacology topic. This time, there is no race. We do not need to chase, because we have no problem with ACE. We respect its space and decide to protest at a different place. Off we go with a little hustle. We barricade the entrance into the vessel's smooth muscle. And I'm sure you know what's next. We also block aldosterone's release at the adrenal cortex. This persistence reduces systemic resistance. And if you measure, this equals reduced blood pressure. As we take a stand, we reduce oxygen demand. No one crosses this road, so we can reduce cardiac afterload. We fooled ACE. It thinks we are soft. We only left it alone to avoid the dry, hacking cough. We have other issues in our sights, like constant monitoring of serum electrolytes. So give an arm if the heart is oxygen starved. We will also mention hypertension. Tell the patient to start yelling for any angioedema or swelling. It's the doctor we are telling, and discontinue is what we are spelling. This patient will continue living, because we know epinephrine is what we are giving. Remember category D and not to take during pregnancy. Remember that first dose when the blood pressure drops the most. To the end we now arrive. Thank you for keeping this channel alive. And if you are new, do not forget to subscribe. Thank you for watching Nursing Analysis. Sometimes it can feel like life is just passing us by. Time is moving fast. And every day the world is changing. Don't get lost in the shuffle. Choose Medical Prep Institute. Help you get ahead of the crowd. Our nursing program is fast, affordable, and flexible. So contact Student Services today to get your start.